In the midst of this pandemic, there's growing concern that people who might be suffering from other illnesses that require emergency care are too afraid to seek treatment, which of course jeopardizes their health even more. Carolee McGrath spoke with Dr. Niels Rathlev, the chair of the emergency department at Baystate Health, to learn more.
Well, the trends have been very dramatic since beginning of March, when COVID first reared its head. The volumes in the ED have decreased by about 50% overall. This has been particularly notable in our pediatric emergency department. At the height of flu season, we were seeing something like 150, 160 children a day. And in the last couple of weeks, it's been closer to 20. So there has been a dramatic drop. And so I think that clearly what this says is that people are afraid of coming to the hospital and coming to the emergency department and are staying away.
When you're talking about the pediatric visits, especially with the flu, I'm assuming that people are afraid and are trying to opt for telemedicine, but how dangerous could that be for little ones who are suffering?
What we encourage families and patients to do is to call their primary care physician first in all cases, unless they have an absolute emergency, in which case, obviously, they should call 911. That would be for things like acute shortness of breath, chest pain. Those are complaints where you really should just be calling 911 and coming to the hospital. For little kids, clearly, we call it respiratory season, when kids get problems with not just the flu, but other respiratory viruses rear their ugly head. And that has abated some. So, flu season is essentially over and was over a couple of weeks ago. But of course, now we're contending with COVID-19. For the kids in particular, what we're concerned about are children with chronic illnesses. Let's say, for example, diabetes, who actually are getting sick because their blood sugars are going too high at home. And we've had several instances where children have come in with very, very high blood sugars and have been in very, very serious condition. So the message here is really, if you are critically ill, let's say if you have chest pain, you're acutely short of breath, the arm doesn't work, you can't speak correctly, symptoms suggestive of a stroke, we need you to come to the hospital. If your diabetes is out of control or your high blood pressure is out of control, you really do need to have it taken care of right away.
Can you explain a little bit how things are set up so that if somebody does call 911 and they're brought into the emergency department, how they are triaged from there?
Sure. So what we do is clearly separate out patients that have symptoms suggestive of COVID-19 from other people. So at the minute you walk in the door or the minute you meet the pre-hospital personnel, that is the paramedics or the EMTs, they will ask you questions immediately, screening questions to see if COVID-19 is a possibility. And they would be fever, shortness of breath, extreme fatigue, muscle aches, nausea, vomiting, diarrhea can also be symptoms of COVID, loss of taste, loss of smell. These are all things that can suggest that a patient has COVID. And so we screen immediately anybody who has these symptoms. We put a mask on, and what will happen is we will treat these patients in a separate area from others. And if you need to be admitted, we test everybody.
I think people probably, as you had mentioned, are nervous and they're fearful and think, well, maybe I should just tough it out. Maybe they might be having chest pains, but maybe they think, well, it could be just indigestion. How dangerous is that for somebody who could be experiencing a heart attack or a stroke?
Well, it could be extremely dangerous because these are time-sensitive conditions. And so for strokes, for example, more than 24 hours out, our hands are really tied, and there are no acute interventions that we can undertake. And the same thing with a different time frame is true of serious heart attacks. So what has happened is that severe strokes and severe heart attacks we are still seeing. What we're not seeing are the patients that have, shall we call them milder heart attacks, or chest pain for other reasons, high blood pressure that's out of control. Strokes, we call them transient ischemic attacks. These are minor strokes where the symptoms come on suddenly and then go away within a short period of time, maybe an hour or two, and then go away. Those are still harbingers of worse things to come if this is not taken care of quickly. And there's a much higher incidence once you've had one of these minor strokes or minor chest pain episodes. Your chance of having a poor outcome when you have a larger event is really much more serious.
And some people obviously aren't quite sure, what has happened as far as those symptoms go. What are the treatments that can be used immediately in the emergency department for a stroke victim?
For a stroke victim, we use clot-busting drugs. If patients come in within a certain period of time, typically 4.5 hours, we can give them clot-busting drugs. This is from onset of symptoms. We can administer this to them in the emergency department. We usually do that in conjunction with the stroke neurologists that come down and see patients. There are patients who can go and get a catheterization in the catheterization lab and receive clot-busting drugs intravenously or intra-arterially. There are specific interventions we can undertake, but it depends on when the patient presents from the onset of symptoms. And this is something that we jump on immediately. And the same thing is true of heart attacks, where the EKGs suggest that this is someone that needs to go to the catheterization lab right away.
And certainly this is not something that's unique to Baystate. What are you hearing from your colleagues across the state and the country?
Yeah, same thing. There was actually an article in the New York Times that said exactly the same thing. Everyone is seeing this across the nation. The message from us who work in the hospital is that if you are not sure, we take great pains to keep you safe and have been very effective in doing that, by the way. We have not had patients that have become ill while they have been in the hospital here. So because of the precautions that we're taking. So if you are concerned, I would not tough it out and let us take a look. And if it turns out that this is just heartburn, then that's great. And we will let you go on your way. On the other hand, if it's something else, then there are ways that we can take care of this acutely. But my concern is that now that we are starting, maybe not in Massachusetts, but in other places, starting to relax a little bit around quarantining and social distancing, that we're not going to start to see more of these patients that should have come to us a week ago or a couple of days ago. And now they're coming and we can't really do much because it's too late.
I think a lot of people, though, when you talk about this, feel like, when they look at the news or they look across the country, that the only thing hospitals can handle right now are COVID-19 patients. So they might feel guilty about, coming in if it is just heartburn.
Yeah, and you have to look after yourself first. And I think that no one wants you to have a heart attack and sit at home while this is happening, or a stroke where, in retrospect, we could have changed the outcome for the better, but it is now too late to really do something. So we separate on the inpatient wards. We separate the COVID-19 patients from everyone else. And the way that we do that is that we test everyone who's being admitted in the emergency department. So before the patient leaves, we know if your test leaves for an inpatient ward. We know if you're positive or negative.
Okay, so bottom line is hospitals are open for business, the same business that you had, except for elective surgeries. And I think that's something that is confusing to a lot of people. That's the message?
Yeah, and I also think I want to reemphasize that we are now 7 weeks into this, and we really have worked out our processes for testing, for protective gear, and separating patients from each other in the hospital when that is necessary. So our processes now are really much better than, admittedly, they were on day one. When this happened, we really took great pains to work out our processes and paradigms so that we were able to keep patients safe. And at this point, I can definitely say that we're able to do that.